Do you have burning questions about scoliosis exercise, bracing, surgery, or post-op rehabilitation? If so, this video is for you. Our company is called the ScoliClinic, and we're located in Vancouver, Canada. It was our clinic's 7th birthday in April, and so we held an open house with an education panel. We polled our followers on Instagram to see what topics they wanted to learn more about. And then we shared these questions with Schroth-Trained Physiotherapist Christiane Junod, Orthotist Carl Ganzert of Hodgson Orthopedic Group, and a client named Miriah who was diagnosed with scoliosis as a teenager and recently had spinal fusion surgery as an adult. Check out the description below for timestamps of the different topics and questions. Thanks again for tuning in. Enjoy this education panel of our recent open house. I'm gonna hit. Great. Hey, Marissa, over to you.
Perfect. Thank you so much for joining everyone today. As Andrea was mentioning, we've been collecting some questions over Instagram over the last couple of weeks, just on common questions that people have for our panelists. So we have a physio, an orthotist, and a client who has her own experience living with scoliosis as well. So let's get started by introducing everyone. So first we have Christiane. Christiane is a physiotherapist here at the ScoliClinic and has been a part of our team since 2018. At the age of 13, Christiane was diagnosed with scoliosis and hyperkyphosis and can relate to many of the struggles that our clients face when it comes to the psychological, social, and biological impacts that scoliosis and hyperkyphosis can bring. Christiane has recently expanded her skill set to include an assessment and treatment method called the integrated systems model. This approach enables her to assess how different parts of the body are interacting with each other and how past injuries or movement habits could be contributing to current areas of dysfunction. Next, we have Carl. Carl is on the far side here. Carl is a Canadian certified orthotist with a Master of Science in McMaster University's Rehabilitation Science program, and he currently works at Hodgson Orthopedic Group. The team here at ScoliClinic work closely with Carl, often when we refer clients for scoliosis-specific bracing. He has a passion for scoliosis bracing and further development of scoliosis treatment concepts. As the acting director of the Hodgson Group's research division, Carl explores an interest in novel 3D printed orthotic concepts and collaborative research models. And finally, we have Miriah. Miriah is a current client of the ScoliClinic and has been attending sessions with us since 2019. She was diagnosed with scoliosis at the age of 12 and elected to have spinal fusion surgery as an adult in January 2023, so pretty recently, due to ongoing concerns of pain despite conservative treatment. Miriah has kindly offered to join us today to answer your questions around someone who has experienced living with scoliosis. We all give a round of applause. Alrighty, so I'll try my best to kind of guide things so that we kind of go in a conversation manner. And at the end, if we have some time for questions, we'll try to leave some time from our audience here as well as some from people at home as well. So I'd like to get started by directing this first question over to Christiane. Yeah. So Christiane can help us answer what causes scoliosis.
Yeah, it's a great question. There's actually a few different types of scoliosis. Actually the most common type of scoliosis is called de novo scoliosis, and it's a type of scoliosis that develops in the older adult years. And likely it's caused by changes to the bone quality. So bone changes like osteoporosis that might lead to a curve developing in the older adult years. The second most common type of scoliosis, and this is probably the type of scoliosis that we usually think of when we speak of scoliosis, is idiopathic scoliosis. And idiopathic actually means we don't know what the cause is. And that type of scoliosis, usually the onset is at around puberty. So usually develops in like starts at around 11, 12 years old and then tends to progress during those teen years. And then typically stays fairly stable in adulthood. And so, yeah, as I said, we don't actually know what the cause of that type of scoliosis is. What has been noticed pretty consistently, though, is that people with that type of scoliosis have wedge-shaped vertebrae in their spine. And the wedge is actually, if you visualize it in 3 dimensions, it's a wedge that you can see from the back view. So if you've got depending on if you have a left or right curve, it's going to be wedged in either direction. And then from the side view, there's also a wedge, going from front to back. So basically the wedge-shaped vertebrae in the spine, one of the mechanisms that we think of, why that scoliosis tends to progress in those teen years is that it leads to having a wedge-shaped vertebrae in your spine, leads to forces being distributed in an uneven way through the spine, where you might get more like compression forces on the one side, more traction forces on the opposite side. Basically that sends a message to the brain to slow down growth on the side where the wedge is like more compressed, and accelerate growth on the side where the like taller, leading to all sorts of like upstream and downstream changes that essentially lead to a structural curve in the spine. So this idiopathic scoliosis is structural in nature, by meaning that there's like physically like a wedge in the spine. But I tend to think of it as still being on a spectrum between structural and postural, meaning that even with those structural changes in the spine, everyone's going to respond to that curve a little bit differently. And certain people might like really find that they lean quite a bit into a curve, whereas others actually like their body kind of figures out how to manage the scoliosis quite well, and end up being, looking at them, you might not actually really notice that they have much of a scoliosis at all. So there can be like a really wide range in the presentations that we see clinically with this type of structural scoliosis. And then, that's like the most common type that we tend to think of. And I think that's probably what we'll mostly be referring to throughout this presentation, or this panel time. But then there are other causes for scoliosis, such as, some people are born with changes to their vertebrae that might lead to scoliosis, or there might be certain people that have neuromuscular conditions that might lead to the development of scoliosis as well. But those tend to be less common.
Awesome, thank you. So that being said, what would you say would be the best treatment options going from the least invasive to the most invasive?
So I actually refreshed my memory last night. There's a whole protocol or guidelines, international guidelines actually around like the management of scoliosis that is a great place to refer to. It's called the SORT 2016 guidelines. And SORT is basically just like an international group of therapists, researchers who basically produce and bring research together on the management of scoliosis. And so, according to their guidelines, there's a range depending on like the severity of the curve and also where like the risk of progression, essentially. So depending on where you're at in your growth, since scoliosis tends to be most likely to progress when you're in your growing years, in those teen years. So depending on those two things, there's a range of treatment options, going from like most conservative, like least invasive would be just observation. So in certain cases where, the curve is not causing any issues, the risk of progression is quite low, we might just be monitoring the curve. And there's a series of measurements that we would do in clinic to do that. And then the next kind of like treatment option that's a little bit more involved from there would be physiotherapy scoliosis specific exercise. PSSE is what it's referred to in the literature. And there's a few different types of PSSE. What most of our therapists here, or all of our therapists here, are trained in is a method called the Schroth method. And so that's one of the PSSE options. And that's, it's a bit different than what, I certainly did not learn about this in school at all. I don't think any of our therapists did. It is like additional training that physiotherapists undergo to be able to treat the scoliosis through exercise. And then from there's also the option of bracing that might be appropriate in certain cases, and I can let Carl discuss that further. And then the most invasive option, or the most involved option, is surgery, and that tends to be for a very like specific type of scenario. So for like curves that are above 50 degrees in teens, or in an adulthood, it's a much more of a last resort kind of option. And Miriah would be a good place to be able to help us understand what her decision making was around that. If anyone's curious around that.
Yeah, come back to Miriah in a sec.
Yeah.
But if I can go to Carl,
Sure.
if you can describe a bit more about what the bracing process looks like for scoliosis.
For sure. Well, it differs a fair bit based on who comes to look at getting braced, and there is a divide between adolescents who are on more of a growth guidance protocol versus adults who are usually coming looking for bracing as a form of pain management. The process starts with an assessment. We take a look at what's going on, what sort of presentation does the curve have, what sort of presentation does the person have, and what are they looking for? Based on the goals that we work on figuring out together, that starts to lend itself to the brace that's going to be the most effective tool to accomplish that goal. Whether or not that brace is custom made from scratch, which is, more of what we do for the adolescents, where we design, fit, implement, and then provide ongoing adjustments throughout that process in the custom side, or if it's a customized brace, which is a pre-made one, which we modify to bring to the best reasonable match. Either way, the tool is either created or provided, and then we start next with the fitting, which we go through, adjusting, tweaking, modifying. I joke that orthotists are a middle ground between the medical world and arts and crafts. The back of the clinic is where we do a lot of the making, the adjusting, and modifying, and so it's a bit of running back and forth, fiddling, tweaking, but bring it to the point we want to send the brace home with the instructions to get going. With any brace or anything, you want to warm up. And so we start off slow. You have to build up tolerance. The skin is not used to having contact in the regions of the body that it needs to interact. So we don't go full-time wear right away. Once we get up to a place where the body starts to work with the brace, we readjust what the times are, what the goals are. And once we hit steady state, for a kid, that's usually what's the maximum correction we can accomplish with a brace. For the adults, if it is pain-based, we look at, more activity modulation. When are we using this? When are we not? But once we hit steady state, the relationship frequency decreases, and then, we're just on hand should the device need servicing, adjustments, tweaks, or modifications.
Awesome. And then with bracing for teens or adults, I guess that'll be a different answer, is what would be the main goal that you're trying to achieve with bracing? We
usually, with teens, any of the growth-based protocols, where the formal goal is prevent progression. Let's keep the curve from getting any bigger. The sort recommendations that Christiane mentioned put bracing as eligible for the moderate curves, which are, between 20 and 50 degrees on the Cobb angle assessment. That's where it's been shown that just physio alone may not be able to halt progression. And beyond 50, it shows braces are not able to really have enough of an effect. So, sorry, could you repeat the question again?
Yeah, what would be the main overall goal?
The main goal, sorry, yeah. So we are preventing progression, and to do that with the adolescents, we need to accomplish a good in-brace correction. We start to straighten out the spine. Bone at the level that we're interacting with it is really just a physics equation. It responds to what is happening to it. And with that wedge in the bone, the tall side is being pulled on in the curve, so it keeps growing faster. The short side is being compressed, so it slows down a little bit. The idea with a brace for a kid is when we straighten the curve out as much as possible, we start to redirect that asymmetry, and we start to hopefully guide the curve to grow into a straighter direction. There are other goals. How do you feel about the curve? How do you feel about yourself with the curve? What about postural symmetry? And, we can get caught looking just at this number of the Cobb angle, but there's a lot more to it there. And I think the goals that start out as primary, once we've got those under control, we can look at secondary ones, which, would be maybe opening the brace up a little bit to accomplish more specific tasks, or if you find certain things you like to do in your day-to-day life are more difficult to accomplish, we can make sure we're mindful of goal number one without not being able to provide an accommodation for the other goals.
Mm-hmm. And then one of the questions that would pop up from what you had just said was, if you are braced and having an in brace and out of brace x-ray taken, should the curve show almost 0 degrees on x-ray or just a lower degree? Or what are you looking for in that in brace x-ray?
Yeah, so we're looking at influencing the skeleton when we're talking about an in-brace x-ray. And the brace, we need an equal and opposite force to do that. So the brace comes in, it's rigid, so is the spine. In between that, we have the skin. And the foreskin is sensitive. So we're always trying to be mindful of that. And ideally, every curve would be corrected to 0 in brace because that gives us the best introduction of symmetry to redirect growth. But it needs to be a balance between what's comfortable and what's optimal for bone growth. And that's something that we accomplish through gradually ramping up correction. Usually with curves, we look for a minimum of 50% reduction of the curve while the brace is on. And again, this is for adolescents. We do have some that go right to 0, but there's many, many different types of curve profiles out there. The longer ones with a single curve, they're far more amenable to bracing. But if we have larger double curves, there's a lot more going on and it's harder to balance that comfort equation. So as long as we see 50, we're happy at the plateau, but the closer it is, the better. And, I do find there is a lot to be said for the kids that are working really hard in the physio with the massage therapy, because a lot of what, provides resistance to correction is muscular tension. If the body has been introduced to the message of the Schroth principles, that's the same thing the brace is trying to do passively. So it's not a surprise, it's not a shock, and there's more acceptance to that position or the guidance of. So yeah.
Yeah, thanks for answering that around teens. And then one more kind of directed around adults. If an adult was to wear a brace, can they expect any curve correction at all in brace, or what would be the main goals around bracing as an adult?
So again, it's maximum tolerable. And as I'm sure most adults have noticed, flexibility compared to when they were 10 might have changed a little bit. So we're going for maximum reasonable, but the goals of pain reduction or, maybe postural improvement, we're not going to accomplish the same 50% threshold. And especially it does start to depend on where the curve is in the spine. Curves that are in the ribs, it's much harder to change that in adults. And sometimes it's just not really tolerable, but curves in the lower spine, we do see larger improvements of, 10, 20 degrees sometimes. But a lot of it is for that realignment to reduce the burden on the muscles. Now, that's all custom. If we switch to the customized braces, which are more compression-based, the softer braces, the fabric styles, those don't have the forces in the right places, and we're not really expecting to see this true correction effect. What we're looking for there is a boost to the muscles. It takes the load off while you're being more active, so fatigue doesn't start to creep up, and hopefully with that, pain doesn't show up in the same ways and flavors that it would have otherwise. So, it's something we monitor, and with adults also, we build up much more slowly, but we don't have the same big aspirations because without growth, there's no opportunity to change the orientation of bone. But we do want to take those asymmetrical forces off as much as possible, because as we do age and bone quality may or may not be maintained, the more symmetrical the loading, the less likely we have for risks of, other sorts of challenges later on.
Awesome. Thanks for answering that one. I guess I'll come over to Miriah. I don't know if bracing was ever a part of your journey, but if you can describe a little bit more about your scoliosis journey, what that looked like for you.
Yeah, for sure. Yeah. So I was diagnosed at age 12. It was caught, my mom had good benefits as a teacher, so she took my sister and I for a massage. And so it was actually a massage therapist who noticed it first, not my physician, but then was confirmed as a diagnosis. But I lived in a small town up north in Alberta, so I didn't actually receive any care after the diagnosis for the scoliosis. When I was around 16, we went down to a hospital in Edmonton, where I was seen by a specialist, but told basically that I was right below the threshold for needing surgery. And I was told I was done growing, so I didn't need a brace, or that it wasn't an option for me, although maybe that is not true, so you should correct that if it's not.
Well, what I do tell people is if you are done growing, we don't have the opportunity to change the bones. You know, there is some studies out there to show that, you know, part-time wear, it can be an assistant to some of the physiotherapy goals, but that's not such an overwhelming body of research at this point that it's gone to the indication level that SOSORT would be looking to provide. But, you know, yeah, like I said, once you're done growing, it's more of the assist for activities.
Right.
So you get a less invasive, less intrusive brace that can help out while you're going for a hike or something like that.
Right. Yeah. So I kind of missed that gap between age 12 to 16, I guess, where I could have had the more corrective brace. I didn't have any pain though at that time from my scoliosis. It wasn't until I would say maybe my mid-20s, I started having quite a bit more pain. And I noticed that it looked like my spine was getting worse, but I didn't really know, right? I still don't know what my numbers were for my curve when I was 16, when I got those x-rays, because those records don't exist anymore, unfortunately. I couldn't find them. But I know it was probably right around below 50, that being the threshold for surgery. And so I thought, you know, it's been 10-ish years. I should probably follow up on this and see what's going on now. Not always so easy to follow up on things either though, right? So I believe it was 2016, I asked my doctor about it. And so he referred me to a surgeon to kind of find out more to see if I would be a candidate for that, all of that. So did x-rays then, found my curve was around 63 degrees at that point. So it had progressed quite a fair bit from somewhere under 50 to around 63. It's like a left thoracic curve. Yeah, I guess with the increasing pain, I knew I needed to do something about it, and it wasn't going to get better as it kept progressing. So the surgeon was actually the one who suggested the ScoliClinic to me, which is great. You know, I think with adults too, surgeons don't want to jump into surgery either. And coming here was great in the sense that it taught me to understand my body and how everything else was compensating for the curve that existed there. So I think when you grow up with the curve, like, you know, I was leaning this way quite a bit, my hip was out to the side, but I wasn't necessarily aware of that in my day-to-day, because for my brain, for my body, that was just my normal. So it actually feels really weird, and you have to think about it to get into that corrective position. So that was something that was really helpful. Just like I understood my body and the way it was set up and the way things were compensating so much better. And definitely did find some relief from pain, as well as greater tolerance for activities. I had really great benefits at that time as well, where I was able to kind of go work out with a physio, not here, but elsewhere, an exercise physio, and work out with him twice a week and be supervised. And that was so essential as well, just to like, again, otherwise I would start working out, but I would immediately get injured and then, you know, wouldn't be able to keep going. So I think that was huge in my journey as well. But it ended up being, so I think it was about 2016 when I first asked to see the surgeon. My surgery just happened 2023. So as you can see, it's not a quick thing here. That said, like I tried the more conservative methods for a while first, but I was still having quite debilitating pain in one spot in particular, where it would limit me from things like, you know, dressing myself, from tying shoes, those sorts of things, for sometimes up to a month at a time, which wasn't really like a feasible way to keep going. So I did go on the surgery list. That was, I think, March 2020. So that was very bad timing, in the sense that it was usually a year wait, and I ended up waiting about 2.5 years. So, but yeah, so had the spinal fusion. It's a journey after the surgery. It is a very large surgery, and I can talk more to that after maybe, but so far my pain is less than it was before the surgery. Yeah, so I mean, we'll see. It's still very soon to see what the new normal will be, but it does seem hopeful.
Yeah, thanks for sharing. And I love that description of not like being able to identify that was the normal in terms of your hip wanting to go one way and then starting to learn that. And then I guess a great question to come off of that is post-fusion. Have you kind of had to refine that center again, or how are you doing with that one?
Yeah, 100%. So then after surgery, everything was different. Actually felt like the front of my body was like twisted more and different, even though my back looked quite straight. But doing physio and massage again after helped. Like there was actually so much tight in the front of my body that had to be released for me to be able to be in neutral, I guess. So it's everything in the body is connected, as much as I really, really sometimes wish it wasn't. I would love for the pain I feel to be where the problem is, but you know, that's often not the case. And so it takes some exploration to figure that out. But I think even after surgery, like, you know, when I looked at myself in the mirror, even though it was different than it had been before, because I had done the Schroth and because I had learned to understand my body, I could, you know, almost understand myself what I needed to do to move. So it's, yeah, it translated across, which was neat.
Very cool.
Yeah.
And then I think building off of that pain side of things, I'd like to ask Christiane, do you think that severity of scoliosis, so severity of curve, equates to the amount of pain someone is experiencing?
Yeah, it's a bit of a hard question to answer because pain is such an individual experience and there's so many things that can go into someone's experience of pain. But I think, yeah, the short answer is no, in that we see clients with small curves with a lot of pain and clients with large curves with not a lot of pain. But yeah, that being said, I was like looking at some of the research last night, and there might be some correlation between, like, especially when we're talking like much larger curves. So not so much with the smaller curves. I don't think there is a relationship between scoliosis and pain, but when we're talking like larger curves, like definitely 30 plus and probably more like 50 plus even, there is a slightly higher likelihood of experiencing some kind of pain or dysfunction at some point in your life, and the scoliosis is likely to be playing a role in that. So it's not as simple like scoliosis equals pain, but it's like when there is pain, you know, and that's part of the work we do as physios, is helping to discern like what part is scoliosis playing in your experience of pain. And yeah, and that, as I said, that can actually even happen in the smaller curves as well. It's just more likely, scoliosis is more likely to be playing a role in your pain if you have a larger curve, if that makes sense.
Mm-hmm. So with pain being one of those goals, what would you say are the other goals that we would have for physiotherapy and scoliosis management?
Yeah, good question. And that's definitely something that we spend quite a bit of time exploring with our clients when they come in, because the goals are and should be personal to each person, but some common ones are just feeling is an aesthetics one. Actually, that's actually one that comes up quite a bit, that people don't really love the way that the scoliosis makes their like shoulders or rib cage or pelvis look. So one of our goals could be just working on getting a little bit more postural symmetry. And another one is just being able to have a higher tolerance to activity, being able to participate in things that people want and love to do. And then of course then there's a goal of like preventing progression. So that's especially relevant in teens when when they're growing rapidly and there's a high risk of progression. But it can be relevant in adults and seniors as well, as especially, as I said, especially in the older adult years when the bone quality starts to change, the risk of progression can get a little bit higher in those stages as well. So then that could be an important goal to prevent progression. Mm-hmm.
And on the note of progression, and I guess Miriah has answered a little bit in terms of her own story, progression a little bit into the early adult years, is that right? Mm-hmm. So can scoliosis get worse in adulthood? What would you kind of expect to see in terms of progression of the year?
Yeah, so it certainly can. Miriah's experience is probably on the more dramatic side of things. I don't think it's common to have such a large progression in a short amount of time, or likely the surgeons would have recommended surgery when she was 17 or 16. But that certainly progression is possible in adulthood. More so, much less likely if the curve is small. So generally, like curves under 30 degrees, we kind of expect them to stay stable in adulthood. But it's once the curve is above 30 degrees that we expect some progression in adulthood. I think the literature suggests like about half a degree a year. Of course, there's a lot of variability, individual variability, but like as a large average, like half a degree a year is something that in the realm of what you can expect. And then for curves over 50 degrees, the average as well that's spoken about in the literature is 1 degree a year. If you have that's part of the reason that they recommend surgery for clients with 50-degree curves as teens, because you can, if you do the math, that can result to quite a lot of progression by the time they're in their like mid-50s or getting into older adult years. Mm-hmm. So progression is definitely possible in adulthood.
Mm-hmm. And then we are very familiar with progression, but how about when it starts? And I guess Carl or Christiane can answer this one. At what age would a family or should a family start screening for it? even considering during growth in the early years as well as in the elder years when we're talking about the de novo side of things.
Well, I think in the in the adolescent population, as much as the teen years are really when it starts to become pronounced, the conversation can get going about adolescent scoliosis as early as 7 or 8. And I think that what I've seen, growth equals change. That's the constant that we have on our hands. And the pubertal growth spurt that takes place around 10 or 11 is a real catalyst of that change. It's not only where things can go awry, but it's also where some real victories can be found in the treatment cycle. So I think starting and leading up to that growth spurt is a good one, because if the factors are in place, it can be capitalized upon. And then, obviously once we hit the growth cessation, and I think it's, I don't remember the stat specifically, but in the 60s, more and more of the adult progression is starting to occur. And then as we go on from there, 70s, 80s, like more and more of the population starts to just have scoliosis due to, normal aging of the body. So I think keeping an eye on things, doing a quick check, looking at yourself in the mirror, do I see my shoulders level? Does it seem different than it was? And I think, especially doing that self-practice, you're starting to observe more about yourself, which, whether or not you're catching progression is just a good thing to be up to. There's amazing diversity and asymmetry in all bodies. And I think that, the more we notice, the more deep, or the more our relationship with ourselves deepens.
And then in terms of once a teen, for example, is braced, how long would they expect to wear a brace for?
One of the questions I get once, not so infrequently. So if the goal is guidance of growth, a brace is eligible until, in most cases, until growth has concluded. So from whatever point they start, usually skeletal maturity is the term we use. So at what point can we observe the bones have finished their growth? 15 to 17 is kind of the given range, but it's rare to find people who are done at 15. Usually I'd say 16 to 17 is the finish. There are kids who we've seen, and I've only noticed this in patients who have worked with a physio as well as done bracing, but there are some that have capitalized on their growth so successfully that their curves out of brace start to creep under that 20-degree mark. And I think at that point, it's an interesting conversation, because although you may have been a bracing candidate, you don't seem to be anymore. So at that point, we might look at downgrading the amount of time a brace is worn, shifting from full-time to nighttime. And, there have been a couple that have gone from their 30s to under 10. And then at that point, the doctor was like, well, I guess we're kind of done here. So as much as that was a pleasant surprise, there is kind of this avenue too out of the brace, which I think, it shouldn't be set as an expectation for anybody, because those really are the remarkable cases. But I think knowing how much you can accomplish at the onset of the journey is a good thing to have in mind. If the best you can expect is hold where you are, that changes our internal narrative. But if the best you can expect is maybe that, there might be a bit more motivation to be found. So, I like to be a bit of a optimistic individual without being overly, or misleading people with the conversation, but it's good to show them the opportunities.
So that being said, if someone is likely recommended for surgery, would bracing be considered as an option, kind of as like last effort prior to considering surgery, even if they're kind of in the higher degree range?
So when you say likely, I guess it depends. If they're right on that threshold of, or we're at the upper edge, like in the mid 40s, we do want to look at the curve specifically at that point. If it's a double curve that's in the high 40s, again, what are the goals here? There is still the ability to halt progression, to slow progression. And I think that can and has worked, but we want to be looking in that sense to individual with a really good mindset who's looking to do absolutely everything they can. You know, if the person is looking at bracing as another in a string of unfortunate events, then, you know, maybe it's not worth going through the introduction to the bracing challenge. I think that, you know, bracing over the 50-degree mark has happened, but it's for different reasons. Usually it's if the surgical wait lists are quite long and we're looking to do some pain management in that time, but it has to be very clear that we're not actually expecting this brace to stop surgery. You know, it likely will happen, you know, and there is some people value the idea of a surgery of a smaller magnitude. You know, a surgery of 55 degrees for the body to absorb, as I would guess, is lesser than a surgery of 85 degrees. But it's important to say that that's not on indication, that's not part of the SOSORT recommendations, and that does come down to more of a personal decision. I think when it comes to these bracing discussions, I break it up into the 3 hardships, I call it, or the three considerations. One of them is the physical experience, the next is the emotional experience, and the third is the financial consideration too. And just being mindful of those kind of helps people as they're considering their odds.
That being said, thinking about leading into surgery, this can be answered by Miriah or Christiane. While waiting for surgery, what would be the benefit of completing exercise? How can it help you, maybe better recovery outcomes?
Yeah, what did you start?
Yeah,
Share your
yeah.
experience.
Well, I had a long time to wait, as I mentioned, because of COVID. So, but I did really see that as an opportunity to kind of build as much muscle and core strength as I could in that time. So, yeah, really committed to a lot of working out, to doing a lot of physio. I think the more, in a sense, the Schroth corrected positions are where your spine is hopefully going to end up somewhere near after the surgery. And so by practicing and being in those positions, it kind of, I don't know, I think the theory would be that it helps the surrounding tissues, muscles, everything, bones to be a little bit more comfortable, or to be like, oh, I've seen something similar to this position before.
Less of a shock to the system.
Yeah, exactly.
Totally.
Although it's still a shock to the system
Yes.
because everything is like, what is going on?
Yeah.
But yeah, it helps you understand how your body feels in that position. But yeah, for me, it was really just building muscle, and because you lose a lot of muscle while you're in hospital. And those are the supporting things, you know, your legs, your arms, your core, that you're really going to need to move once you're post-op and you're trying to keep your spine as straight as you can. So yeah, that was a big one for me. And then I think also just psychologically, like, it is a big surgery. It can be a traumatic thing to go through. And, you know, it's weird to have something that's traumatic that you can almost plan for. You know, often trauma is the unexpected nature, but I think we're able to access, you know, mental health care in the time leading up as well. That can be really helpful just with thinking through the things you might experience or feel afterwards.
Yeah, that being said, with that idea of planning for something, even though it's a traumatic thing, did you do anything in your prep ahead of surgery, whether psychologically or physically, for like your home setup or anything?
Yeah, totally. So yep, I did like I said, as much muscle building as I could, and getting my heart rate up too, so that my heart was nice and strong. I'm a nurse, so I had some understanding of like what it's like in the hospital, what it'll be like post-op, although obviously it's very different as a patient. But part of that was also explaining to my family like what to expect after the surgery, you know. So helping them understand that as well. You know, you might not be able to see me the first day, depending, like those kind of things, so that they had some better idea of what was going to be happening. And then also just at my home, setting up a lot of things. So setting up, I was lucky that my benefits covered actually, like, you know, raised toilets, a shower bench. So I was able to buy those things in advance and then have them covered by my insurance. So check your insurance if you're thinking of surgery, check it out and see if it would be covered. So I could install those things in advance. And then I also bought a lot of things that like buttoned or zipped up. So because I wasn't sure how I'd be putting things on overhead right away. So that was something where I just had, you know, like some nightgowns, some sweaters, all things that were front closing. Yeah, but if you don't have the insurance to buy the toilet seats or things like that in advance, you can get them through Red Cross for free if they're needed, but it's kind of like they'll write it for you the day or two before surgery. So plan to have someone who can go get them while you're in the hospital and install them in your place. That you can't really do it in advance. Is the downside of that one. So yeah, I would say environmental stuff, and then also like physically, mentally getting ready.
You sound so well prepared. That's awesome.
Yeah.
Was there anything that you wish you knew before the surgery that came up after?
In terms of like stuff at home or just in general?
Stuff at home in general?
Yeah. I think like, yeah, if you've never been in an inpatient hospital setting, like it can be quite hectic and chaotic. People are going to be coming and checking on you every few hours, maybe every hour at first, maybe even more. So don't expect to get like a ton of sleep. I think I went home and I had to catch up on all my sleep from when I was in the hospital. I took a lot of stuff with me in terms of like things to do to distract myself, like a tablet with some movies, some audiobooks, some music. But to be honest with you, the first week I had no interest in anything. Like I was just so tired. I didn't even want to look at my phone. But having it there still was nice as a backup. And obviously I had people there a lot to visit me as well. A concern that I had going into it was when I'm really out of it those first few days, making sure I'm knowing what meds I'm getting, or that someone is double checking that. And I mean, the nurses are great, but they're also way overworked and we have way too many nurses, like way too few nurses for the number of patients. So just advocating for yourself and your own care is huge. Like if you're not sure why you're being given a certain med, ask, like that's your right. So I think that's something important for everyone to know. Other than that, I mean, I have a fairly large numb section still on my torso, on my back. I don't know that I was expecting that much numbness, but I've since read that can be pretty normal. And if it's nerve damage, that does take quite a long time to come back. It's like, I think, 0.5 millimeters a day or something?
Yeah, that's a big one.
Yeah, it's quite slow. So that's interesting. On the other hand, I think that's maybe why I haven't had a ton of pain right in the spine area. So maybe it's a bit of a gift as well. Another thing I wasn't aware of right away was that they had actually broken two of my ribs away from the spine on this side. So, you're trying to turn in the hospital and lie on either side. And I was like, why is this side getting so painful? And then my surgeon's like, oh yeah, we broke some ribs on that side. And I'm like, okay, that would have been good to know. But then I knew and I could stop lying on that side. So I was fine. Yeah, I don't know. And I mean, that's my experience. I ended up being in the hospital. I was there for about 12 days. But if it's, which is a long time, it's a major surgery. If it's your child who's getting the surgery, they're going to be out a lot quicker than I was. Yeah, exactly. So yeah, it could be a few days for a kid. Yeah, for me, it was 12 days. I mean, I did lose quite a bit of blood during the surgery and needed some transfusions and that sort of thing, which meant I couldn't get up walking as quickly. They'll try to get you up the next day or the second day. For me, it was a bit longer because I would have been too dizzy because of losing that blood. Yeah, I don't know. It's an adventure. There was someone down the hall who played loud music, like loud movies all night long. So that part was interesting in that you would just hear like this action music or like fantasy music. And you're a little out of it on the meds and you're like, am I? What is happening? Yeah. So yeah.
So how early should someone expect to see their physio after surgery? I guess this question could be for either Miriah or Christiane.
I mean, your surgeon will tell you. So you're not supposed to do it before your surgeon tells you. So you'll see the surgeon in about 6 to 8 weeks. They'll do other repeat x-rays. And if things look good, then they'll say you can start like physio, massage, that stuff. That said, you do see physio right away in the hospital. They're the ones who get you up, who get you moving. And they may or may not give you like a few exercises. Like for me, it was a few core exercises to do in bed. So like those ones I could do right away on discharge, the few that they had given me, but I wasn't supposed to see anyone else until cleared to do so.
Yeah, and I think pre-op we talked about a few things that you could work on as well, like during that time. Because there's certainly certain things like there are a lot of restrictions in those first 6 to 8 weeks post-op. So in terms of movements that you're allowed to do. So I think that's why they tend to say, stay away from too many appointments during that time. But there's still a lot of things that you can do to maintain a certain amount of strength and start rebuilding a little bit of endurance and things like that. So we often end up talking about that either pre-op or else it's happened a couple of times where we've had a few like virtual sessions with clients in like those first few weeks to just like help guide them through those like and even just like things like getting in and out of bed will feel quite different like after that surgery where you're not supposed to be twisting your spine at all or bending your spine. So you're having to be really mindful about movements that you never like really gave too much thought of pre-op. So we spend quite a bit of time talking about that before the surgery. And then sometimes it's helpful to have that little bit of guidance in those early weeks as well. Yeah, and we're happy to provide that.
Okay.
So what kind did you have though? Did you put a rod in or?
My surgery, yeah. Sorry, I guess I should have said. So yeah, it's a spinal fusion with rods, T4 to L4. So quite a
Pretty
big,
much the
most
whole-
of my spine.
Yeah, most of the spine.
Yeah.
Doesn't it actually move on spine?
Yeah. So yeah,
That means you can't bend it.
that part of my spine doesn't bend, but like I can bend from my hips basically. Yeah. Or yeah, if I want to pick something up in the way we all should be, instead of, you know, bending over and picking it up more of the squats. Yeah.
Yeah, it's a pretty crazy surgery.
Yeah. It's a very
it's
massive
like they had to
surgery.
put like pins like at every vertebrae, and like there's rods on either side of that. Yeah,
Is there an age about which they won't do it? Like, I feel like I'm getting close, so I have to make a decision.
I mean, my student said that for most people he operates are actually like 50s, 60s. Yeah, so he said most of his operations are on that age.
I'm not sure what the upper cutoff of that'd definitely be a good question to ask the surgeon, but yeah. I feel like
I
over
find-
70.
I think that over
That's true, too.
70, they start to look into more of the specific factors. What is bone quality, overall health status? You know, do you have any other complications that are going on, or any other reasons why? Because I think a lot of it comes down to, there's like will the hardware take, and will the anesthetic be a concern? So if they don't have reasonable issue with that, then, you know, it will go over the 70-year-old marker.
That being said, with having a weaker bone structure hypothetically, how would that impact something like bracing or physiotherapy for considerations around that?
Sure. A weaker bone structure. Yeah, I mean that it's, to me, that just like reinforces the point that you need more strength to be able to support your spine. Because a weaker bone structure means that you're likely at a higher likelihood of progressing, progressing, and yeah, and then there's risk for things like vertebral fractures and things like that. So yeah, being really mindful of like how you're moving and having like the strength that you need to support those movements is really important. Yeah, I don't know if this is a good time to talk about the core, but I feel like good core strength is a really important piece because the core is really essentially what's supporting your spine. Yeah, and I know that's advice that's like commonly given by physicians and physios and the internet and all the places. And I find that that it can actually end up being a bit confusing, because when you Google core exercises, you'll get a really wide range of exercises, and a lot of them will include things like planks and crunches and curl ups and like, yeah, a wide range of exercises, which actually like they can be helpful, but they don't necessarily get at the deep like core structure that you need that actually is supporting your spine. So I like to think of the core as having like two different like layers to it, where the top layer is that kind of six pack that you think about, and it's those muscles that really help with bending forward and twisting your spine and things like that. So I think of them as movers, and those are the muscles that are usually targeted by those core workouts that you find online. So good for them to be strong, but you don't necessarily. Yeah, this second layer of muscles that is more like the stabilizing muscle group. Those muscles, like depending on, and that's where it's worth like often having like a specific assessment, because they don't always turn on the way they should, especially with a history of back pain and scoliosis, I think as well, like makes it harder to access those muscles sometimes. And so yeah, having a little bit of like more guidance around core work can be really, really helpful. Because yeah, those deep core muscles are really what control the vertebrae, like vertebrae by vertebrae, and like facilitate elongation, whereas those like superficial muscles actually tend to lead to more compression if they're overactive and if they end up taking on the role of stabilizers. And so it can be a little bit counterproductive to be over focused on those like strengthening those superficial core muscles. The beauty of Schroth and of the physiotherapy specific scoliosis specific exercise is that those exercises do a really good job of engaging those deep core muscles and facilitating that elongation that supports the spine as you age.
Yeah, great answer on the floor with that.
Okay.
So when it comes to deteriorating bone quality, I'd actually like to wind back to my first question, which I was busy forgetting what the question was that I was answering, and forgot to mention that in adults, one of the goals is preventing progression. And certainly with a decrease of bone quality, we run into risk of acute vertebral issue. Sometimes we can see a wedge that gets broken out of the side, and we start to get a curve that used to be, very smooth, have a sharp angle show up at one point. So, with bracing, we are looking to hold that away. But when we have decreased bone quality, the introduction of the bracing process, usually we're just looking to be a little bit more gradual as we start to apply pressures, give the body more of a chance to get used to it. And we might even start with some modified wear strategies where we can do the application of the brace laying down. That way we have gravity out of the equation. We're not being pressed into the curve, and the body can start to get used to the contact and the elongation that comes with the brace without having to offset gravity's forces. Yeah. So there are strategies, and it definitely bears consideration. It's one thing to be mindful of going into the process for sure.
The next question anyone can answer. Are there any restrictions on regular physical activities for someone who has scoliosis, and will excess movements make it worse? So whether it's an activity of daily living, like your day-to-day movements, or particular exercise like ballet or acro or things like that.
Yeah, I think for me, like twisting or bending could be painful. Especially like, a bend and twist to move something, that sort of motion.
Are you talking pre-op or post?
Pre-op, yeah. But then also the pain could be totally random. So, which was part of the hard to manage part of it, is that this really awful pain I would get that would limit sometimes I have no idea what brought it on. So you can be careful, but also there's an element that can be mysterious.
Yeah, totally. Yeah, I think the recommendations that we usually give are just being mindful of movements that you're repeating a lot, that you're loading heavily, or that you're spending a lot of time in. And so, avoiding movements that are taking you at the very end of your range of motion. So whether that be twisting or bending forward or bending backwards, that's usually the rule of thumb that we give. But when it comes to participation in sports and activities that you enjoy, so long as you're not experiencing any pain, and that that the movement isn't feeling really off for whatever reason, then most likely you're safe to continue with those activities.
Yeah, I think for me, again, not being kind of the physio side of expertise, it's an interesting one, because some people come in and they're worried that if they sneeze they're going to fall to pieces. And scoliosis doesn't necessarily make you fragile. It just is asymmetry in the body, and asymmetry taxes the body harder than symmetry. So acknowledge that, work towards bolstering your strength and your capacity as well as your mobility. Within that, what I tell a lot of my patients is like, nobody wants this to define them. If you have glasses or braces on your teeth, you don't go up and say, hello, I'm somebody with glasses. I am Carl, and I think within that, part of your identity is the activities you like. And, we want to be managing this, but still pursuing the things you enjoy or your passions. So, we need to talk about them. You can't just all of a sudden take up bungee jumping if you've never tried it before and haven't talked with your physio. But I think that there's lots that can be done.
Absolutely. Yeah, and I find what's more important is actually it's again like kind of the strategy that you're using when doing those movements, which the curve might predispose you to certain movement strategies that aren't optimal. But there's a wide range, as I said, of how people actually respond and what strategies to employ. And that tends to when we're talking about in terms of pain, in terms of function and people being able to do activities, it often comes down to like the way they're doing the movement. And so usually that's something we're able to problem solve and find something that feels good when we're in our physio sessions.
Mm-hmm. Does that change at all when someone's in a brace? Like would their
Activity-wise?
ADLs or activities change or have to be monitored?
Yeah, so the braces, so I guess I'll speak to custom or customized. And again, I like to fiddle in the nuances and differences here, but because the plastic braces are rigid, they hold the body in the best position that it can accomplish. They don't really get in the way of people doing normal non-exercise or higher level activities. So walking around, going to do, whatever activities with friends, going for lunch, even chores and that sort of thing. People get so used to the brace. I often have people tell me they forget they're wearing it, which would seem unlikely on day one for most, but it's amazing what we can adapt to. And, but for sports, for physio, for high level activities where you might be sweating or exerting at a increased heart rate, take the brace off. Go have fun, but use your muscles. A brace is, it's a vacation for the core musculature. It just gets to hang out. And as much as the body loves to do the minimum possible, one of the risks of bracing is deconditioning. That is well managed both in evidence and anecdote by, physio and extra exercises, but it is something we want to be mindful of. And I think just at that higher level of gym class or a run, it would get in the way. We want to be exercising like unimpeded there. So that's the case for custom, but for the customized, being the softer, being the more malleable, the ones that work with you, I actually encourage people to wear those 4 activities. Some of them are as simple as just a bolstered low back pain brace. That's just help the thoracic segment of your spine make a stronger connection with the pelvis when you're going hiking. Or I was even chatting with a lady the other day about riding horses with their brace on, and you wouldn't want to do that in a plastic brace, but it's a great thing to have with some of those customized braces that just give your spinal musculature a boost.
Mm-hmm. And then kind of left turn, but similar, thinking about lung functioning while wearing a brace. And then maybe if Christiane can speak to lung functioning in general, scoliosis after.
Yeah, so breathing's important. We all do it most days. And with bracing, I think that the restriction on breathing has decreased as the bracing philosophies have evolved. Back in the day, it was more of a 2-dimensional style of bracing. Braces like the Boston, Junod, Providence, Milwaukee, they were more looking at an x-ray and, well, let's just put here, here, and here. And it was almost kind of a clamp effect, which as the wearer of the clamp, less ideal, but also restrictive. Whereas the current state of things, the best practice style is called 3D asymmetrical bracing, and that just emerges from the acknowledgement that scoliosis is a 3D asymmetrical position. We know, as much as Christiane mentioned idiopathic, we're not sure exactly why, but we do know what, and we know how the body has got to the position it's in. The custom braces reverse that, and wherever they press, they give room to go. A lot of it is done by redirecting breathing, guiding breathing. We don't give the body the option to breathe excessively into the curve. I know that the term breathe into your valleys floats all over the place here. And whenever I'm introducing the brace, I'm like, here's your valley, this big open area here, and you will fill this up more and more. So, by and large, people do find that they're not restricted from breath beyond the first minute or so when they first put the brace on. I do like to caveat that first minute or two with the brace to tell them that ahead of time, that like, you'll get to a 7 out of 10. Don't worry, your brain just needs a second to figure it out.
When it comes to respiratory function, like your ability to actually be able to breathe in a way to, stay alive and get your heart the oxygen it needs, scoliosis won't affect that respiratory function until the curve is, in the like 80-90 degree range. So like really, really severe scoliosis. That's when in the thoracic region, that's when you might have an impact on your ability to actually get enough oxygen in your body. But yeah, with the more mild curves, your breathing pattern will likely be altered in that kind of like what Carl was mentioning, because especially if you have a thoracic curve that's impacting your rib cage symmetry, there's just going to be certain areas where your breath will want to go to because it takes the path of least resistance. And so if you've got, there's certain parts of your ribs that are more compressed and others where they're more splayed and there's more space, then your breath will naturally want to go to those areas. So that's where you might feel like you're breathing a little bit into your curve at times. The nice flip side of that is that gives us a great avenue for treatment, in that a lot of the exercises that we use here based on the Schroth method are like using your breath to your advantage, where we're actually able to consciously like redirect your breath to parts of your ribcage which don't normally get as much air, and that helps to then reshape the symmetry of that can facilitate the regaining some symmetry within the ribcage. So it's actually a fantastic tool. What was your experience? Did you find that your breathing was impacted pre-op by your curve?
I do feel like it was harder I could take a deep breath, but it was difficult to let it out slowly all the way. And then post-op breathing was hard at first. And it was kind of when I got a massage and released my diaphragm. And then I took my first deep breath and like everything moved and I was like, oh, I forgot how good it feels to breathe. So that was probably nearly 3 months after the surgery. So at that time, I was trying to do things and take deep breaths and but just really couldn't. There was no movement. Like here, nothing was moving, everything was kind of frozen. So
yeah, that's interesting, because then that speaks to how like the structure of the spine actually is what's limiting the intake of breath. Sometimes it's actually more like the myofascial, the way the body is responding, the muscle tissues that are responding to whatever's happening in your body that could be impacting your ability to breathe or take that deep breath in.
Good point. Speaking of the muscles, this is my personally favorite question we got from Instagram. And what do you do with the shoulder blade that sticks out?
Yeah, so a common curve pattern that we see is a right thoracic curve, which would mean that your rib cage is translated to the right and a little bit rotated to the right. And the shoulders often respond to that type of rib cage position by rotating in the opposite direction, where the right shoulder will often like come forward and like tip out the back a little bit. And so some people, and different, as I said, different bodies respond in different ways, but some people have the experience of having a really pointy kind of a shoulder. Yeah, I see someone raising their hand there. So that's a common experience. I guess the first line of treatment, or how we would address that, would be by, first of all, like trying to regain as much symmetry within the rib cage as possible. So as I mentioned, like using your breath to do so can be a really effective way of like breathing into onto the inside of the curve, breathing a little bit forward into the front of the curve. All of that kind of helps the rib cage to be less translated to right, less rotated. And once the rib cage is in more of a neutral position, sometimes the shoulder will actually just kind of relax back and end up in a more neutral position because it's not being pushed forward as much. Other times, a little bit more specific treatment to the shoulder is needed as well to just help the muscles kind of adjust to that new position and to just build strength in a position that's more neutral. It's almost like a lot of the treatment around scoliosis is really retraining your brain to move and to think about your body in a way that's more symmetrical. Because these postural changes are things that have happened over like such an extended period of time that the more neutral symmetrical posture will actually feel quite strange and foreign at first.
Speaking of symmetry with posture, are there any considerations of pregnancy and scoliosis?
So that's actually a common question that we get is like, have scoliosis, how is pregnancy going to affect things? According to the literature, actually, there is very little impact of scoliosis on pregnancy, meaning that, there isn't any higher incidence of complications, less, not a higher incidence of C-sections, and likely no progression of the scoliosis as well with pregnancy. So that's pretty good news from a literature perspective. I'd say like from a clinical perspective and what we've observed is that there can be changes to those postural strategies that occur with pregnancy just because it's pregnancy is a lot, and your body is under a lot of stress. And so that, there are times where if you already have some postural tendencies that take you into your curve, or and actually like probably even more so if you have some tendencies to be kyphotic and to bend through your upper back, those tendencies can be a little slightly accentuated with the pregnancy. Nothing long-term and nothing that can't be overcome with some support from a physiotherapist and participation in exercise. And a pelvic floor physiotherapist, I would say, is also helpful to have support from a pelvic floor in pregnancy.
Awesome. I have one more question that I'm going to ask. I know we've been all sitting for quite some time, and then I'll open the floor to some questions. So in considering something more traumatic like a motor vehicle accident or any other trauma, can that make scoliosis worse or develop a scoliosis?
In most cases, no. In most cases, it is a question I get as well as a motor vehicle accident will likely not make your scoliosis worse. It might impact, again, those postural strategies because that was like a trauma to your body, and the body often responds to trauma by tightening up and compressing. So, you might feel a little bit tighter, or you might feel like you're a little bit more into your curve. But if we were to take an x-ray before and after, likely the numbers wouldn't change drastically. The one exception would be if you had like an actual vertebral fracture, that would then affect the symmetry of your spine, potentially that could cause or worsen a scoliosis.
Anyone else have any other thoughts?
I would say it would just be speculation, but I think that, like Christiane mentioned, injury does cause the body to lock down to try to stabilize areas. And it depends on where you get hit, the mechanism of injury, what happened around it. But, anecdotally in clinic, one jumps out to me that there was an individual who his only injury he could think of was getting hit playing rugby really, really hard in the ribs. He had known through other medical considerations that he had not had scoliosis in his teen years, and then a mild scoliosis had shown up kind of in response, or not in response, but like after the impact. So I think that body's quite a fascinating thing in the way it responds to these things, and it wouldn't cause necessarily like a bony structural response for sure, but it can cause our posture to shift. And I think that it wouldn't really be necessarily something that I would jump to bracing for, but certainly on the conservative management side to do these releases and these I think one of the things I appreciate about working with physios here is it's not just the PSSE knowledge, it's all of the other techniques, the breadth of physiotherapy that can be brought into the treatment as well, to help the body kind of move past some of these things.
Thanks again for watching the recording of our education panel. We're hoping to hold more of these in the future, so follow us on Instagram at the ScoliClinic to participate in polls. See you next time.